Welcome to The Ideas Machine, a podcast about turning ideas into action. I'm Helena Traill, a neurodivergent designer, painter, founder of New Studio, and relentless storyteller. I chat with creative thinkers about how they ideate, iterate, and implement their ideas. This is your space for honest conversations, creative tools, and a reminder that your ideas are worth building. Anyway, today I'm really excited to be joined by my friend and colleague and collaborator, Dr Lia Ali, and we are going to talk about lots of different things. I don't know where we should start, but would you like...
There's so many places to start. First of all, thank you for having me. It's really nice to be here and to have a more, like we have these conversations all the time, but it's really nice to do it together.
Except now we're here with producer Rue, lots of microphones and lots of cameras, no pressure. Anyway, would you like to introduce yourself? Where should we start?
So I'm Lia. I am trained as a doctor, so I went to medical school, did the whole medical school thing, and then I subspecialised in an area of mental health, so I'm a consultant psychiatrist, so I still practice clinically in South London. And then on my journey, I have kind of gone through a few different things, and I've ended up working in industry at national policy level, and also getting some design training. And a lot of what I do now is taking a design-led approach to digital health strategy in particular, but thinking always about the person in the full context of how they experience the world.
And you were going to tell me a story about what you wanted to be when you grew up.
Yeah, so I have this story that I tell, that when I was little, about 6, I went on holiday to, my parents took us to Houston, and we went to the NASA headquarters. And I can remember going into, it was like an early IMAX cinema setup. And they showed imagery, a film that was full of images taken from the Apollo missions. And there's that really classic Earth-rising footage, which we've seen more of with the Artemis mission recently. And it's really brought that story back to me, because I can remember being really little, and I'm still pretty little because I'm very short, but even then I was even littler, and I can remember looking up and just kind of being in awe of the beauty that you saw. So, you know, there's this green and blue ball floating in this sea of nothingness. It's exactly how, you know, I remember being overawed by it, exactly how you heard those astronauts on Artemis describing it. It was just, I can remember it having a really profound impact on me. And I did 2 things. I was obsessed by 2 things when I was that age. One was space travel, partly because of this trip and seeing this incredible imagery and all the technology and all the innovation, seeing all the rockets that had been out into space, etc. The other thing I liked to do was I had a Cindy doll, which I don't even know if people know what Cindy dolls are, but they were like a cousin to Barbies. And I would make clothes like little kids, so I would dress my dolls up. But I couldn't sew. So I would take bits of tin foil and sticky tape things, and I would make little outfits, and I'd be thinking, I don't know, I thought I was going to be like some kind of cross between Vivienne Westwood and Neil Armstrong, space exploring fashion designer thing. And what I talk about quite a lot when people ask me about my career journey is that I think I've always had that kind of mix of wanting to know where beauty comes from, there's something about, I look at something, particularly patterns, texture, colour. I'm quite into thinking about interior design, etc. now, but you know, back then it was making my little clothes for my Barbie, and thinking about how do you create that, and where do these ideas come from, and always being really interested in where does this new stuff come from, and how do you make things look really beautiful. And I obviously didn't end up being either a fashion designer or an astronaut, sadly, although I did get quite a long way down the astronaut, properly thought about going and doing aeronautical engineering at university, but ended up doing medicine, and was always really interested in memory. Actually, that's what took me to a few specific experiences. So one of the very early experiences I had was going to a university called Duke University in the States, and I was on a special program called Exploring the Mind, and you looked at a topic like memory or language from multiple perspectives. So we looked at memory from the perspective of philosophy, cultural anthropology, neurobiology, linguistics, and you would take all of those different perspectives and for me, this is again this kind of the beautiful thing in something like space exploration is you've got multiple perspectives, multiple disciplines, lots of people who are coming together with ideas and ways of working, and that somehow magically, synergistically becomes these incredible things that take us to the moon and back again. And there's something about that endeavour that I felt quite passionate about in my early days of doing my medical training. From early on looking at ideas around memory and language and cognition, all those sorts of things. And then through into when I qualified, during my training I did research on things like consciousness, so how you can define and find physical signals of different type of consciousness related to how much you can remember and different types of memory. So quite neuroscientific, but also these sort of very philosophical, conceptual things. And took that through into my training and knew that I probably wanted to end up on a path towards thinking about the psychological concept more, and ended up in psychiatry. And spent most of my career thinking about how you design services that really go across the fullness of someone's experience. And in my world, we talk about something, in my health world, clinical world, we talk about something called the biopsychosocial model, which is really, really hard to say. I think you can say it, Helena. Can you say it?
Biopsychosocial?
Excellent.
Did I say it wrong?
Yes, yes. No, you said it perfectly. You have had years of me bugging you about it.
This is my favourite story. Carry on.
So, biopsychosocial model, it's difficult to say. It's not that difficult to get, actually. I think people intrinsically know that this is true of human experience. You don't think about somebody just in the biological bit, the medical bit. You think about them in their psychological and their social context as well. And I think one of the phrases that I often talk about that kind of explains this position comes from a Roman playwright called Terence, who said, "I am human. Everything that is human is interesting to me." So for me, that just encapsulates this position of seeing somebody in the fullness of who they are. In the globalised north, in healthcare, we have very much a different position to that. We have a medicalised transactional model of health. And that's encapsulated by another philosophical saying, which comes from Descartes, who said, "I think, therefore I am," which in my world translates to this disconnection between mind and body, because you have to think and then you are. Whereas actually, that's not really how it works. That's not even how we evolve. When you think about, the neurobiology of how the brain develops, for example, you very early on as little babies, we respond to certain things, we develop those skills, and it's all about feedback. It's all about how we're sensing the world. So, there are these incredible studies that looked at, for example, children who were brought up in the Romanian orphanages. And those children who didn't have certain types of stimulation at key points in their development, they started to look like they had certain psychiatric conditions. And it's all to do with this disruptive interaction between how they were growing and developing and how they were sensing the world. So far from it being "I think, therefore I am," for me it's more like that Terence position. It's more like "I am, therefore I think." Your experiences of the world, what you're seeing and feeling and hearing and touching and smelling, all of those senses, they inform who you are and how you develop, and actually what your later experiences of the world is going to be like. I can give you a clinical example. I was thinking of the pain one. So we know that pain is, from a clinical scientific evidence base, we know that pain is not correlated to the amount of tissue damage that we have, which is quite a sort of not intuitive thing to say when you sit like we do in the globalised north with a healthcare system that thinks the answer to pain is a drug of some sort or an intervention of some sort. And yet we know we have lots of evidence, particularly in chronic pain syndromes, where the more effective interventions are the ones that do this biopsychosocial thing. They look at somebody in the fullness of what they're experiencing. So in my clinic, for example, in my clinical work, I see people who have symptoms that look like seizures, and they very often, sometimes you can see something that's a physical, it's a tumour or something that seems to be related to the onset of the seizures, and it's very epileptic. But quite often the people that I see are the ones where you haven't got that, but you have got other things going on in their psychosocial experience. For example, these types of non-epileptic seizures occur more in people who have history of trauma early in childhood in particular. It comes back to that I am, therefore I think thing, where your early experiences of the world shape what your physical interaction with the world looks like. And that can be really profound for actually how you treat those people. And I think sometimes our healthcare system fails people because we don't think about people in the fullness of that. And that's something you and I are really interested in addressing, aren't we?
Yeah, well, thank you. And in terms, before we kind of go on to how we met and worked together, what does your weeks look like now? What are you working on now?
So I do a few different things. So I have my clinical work that I've described already at the South London and Maudsley. Then I spend quite a lot of my week working for NHS England. So I have a number of different things. I'm a clinical advisor, which means I advise on different types of pieces of work. Sometimes it'll be policy work, sometimes it'll be development of national products. So for example, at the moment I advise the NHS App Senior Leadership Team. I also do some work around the use of digital therapeutics in the national channels. I am also working around shared care records and thinking about care planning. And the sort of common theme across all of these is, again, this biopsychosocial model. What I'm interested in is how do we make our services fit more around people rather than making people fit around our services, the way our services are set up. And probably the main place that I do that at the moment is in my work around something called neighbourhood policy, which is a big piece of the 10-year plan and thinking about how we're going to deliver health services. And at the core of neighbourhood is the biopsychosocial model. It is about how do we produce these shifts to think about how we shift from disease to prevention, from hospital to community, and from analogue to digital as the other of these three DARSI shifts, they're called. And for neighbourhood, it's very much this hospital to community, disease to prevention part, of which we really think that helping services understand how to do that in a biopsychosocial way is really where the benefits are. And that's what the evidence base tells us. It tells us that when you do that, you improve health outcomes across pretty much every long-term condition, and you also optimise system key performance indicators. People present to A&E less, they present to doctors less, so you get those impact like on waiting times, etc., that we're always looking for.
So I'm not very good at asking questions today because I always find it so interesting listening to you speak that I'm like, yeah, keep going. I don't want to interrupt.
Well, I guess the only thing that I didn't talk about that we're going to talk about in a bit, the third part of my week is the design research work. And I really love that. I have to do that in a couple of different domains. For example, at the moment, in the sort of academic sphere at Imperial College, I'm doing work looking at how mould in housing is related to respiratory complications. And that's very much inspired by the case of a little boy who died in the north of England from respiratory complications of mould. And what I'm looking at is design-led ways that we can, and we will be looking at that together, is looking at ways of how you can help distributed systems of stakeholders and people you won't think of, like not necessarily health, like housing, local authority, industry sector. How do you drive innovation in these spaces that can solve these complex, wicked problems?
And that's our favourite thing, a good old wicked problem. It's interesting that it almost comes full circle back to NASA and space and fashion and looking at people as a whole. So should we touch on how we met?
Yeah.
I'm me as a designer, yourself as a clinician. We both found ourselves, when did we start our masters?
I can't remember. It was post-COVID. It's like 2021,
something like that.
Yeah.
And the masters was in healthcare design. At the Royal College of Art and Imperial. So I enrolled from the Royal College of Art side and yourself from Imperial. And I always explain it as 20 designers in a room, 20 clinicians in a room, and it's how do you find that kind of middle ground of collaboration to create innovation within healthcare. and we both remember one of those first weeks at the
Yeah.
art school side, doing an ideas sprint. Do you want to tell that story?
Yeah, so there was this exercise. It was a brainstorming exercise, and you had to write down, or draw ideas. And I can remember just being blown away because Helena did about, I don't know, something like 80 or something in the time that we had. And I did something like 35, 40, which I was pretty pleased with.
It was good.
I have to say, I did the most, I think, out of the clinicians, didn't I?
I think you did. I think some clinicians did about 10.
Yeah, and it was, and the way they taught us, but it was so interesting to me. And I can remember you and I having a conversation about this, about why was this the case. And our lecturers had been teaching us about how, certain different disciplines, when you come into different disciplines, you're taught and you constrain your thinking in different ways and expand your thinking in different ways. There's good and bad in both. And I can remember you and I having a conversation about it and talking about this difference in how we do that. And I remember you saying, well, Leah, you're talking about how you've been taught to do critical appraisal. So I've been taught to do critical appraisal, which is a classic scientific methodology where you will look at the evidence base. You're taught the rules of understanding statistics and confidence intervals and all of these things around looking at a scientific evidence base, doing things like null hypothesis testing, where you'll constrain variables within your environment so that you can test one thing. And you were saying to me, Helen, I remember that just like I've been taught to do that, you've been taught to do something completely different. Yeah, I don't know. Do you want to say?
Well, it was all blue sky thinking, innovation mapping, whatever you want to do, jump how high, and not thinking about those constraints. So within standard design methodology, it's called the double diamond kind of design methodology. And it's all about going convergent. I was getting the wrong way around, but convergent and then divergent. So coming up with loads and loads of ideas, good ideas, bad ideas, and then narrowing them down and improving them. But that first bit was the difference between it was almost like a room divide between clinicians and designers.
Absolutely.
And it was this idea that, you looked across the table and went, but Helena, how many of those can you do? And I said, well, at this point, it doesn't matter. I hadn't even thought about the constraints. And I was almost a bit embarrassed. Everyone's going, wow, you've done 80. And I was thinking, well, some of mine are just a stick man and a random idea. And, how useful are they going to be? But that kind of literally the ideas machine, name of the podcast, this idea that we'll just get your ideas down, get them all written out, and then converge and, actually work through them and improve them and iterate on them. I think that was really fascinating, and almost the whole masters that we did, I think, was about almost making a level playing field between clinicians and designers and finding that middle ground that if we did it again, maybe you would do 50 ideas and I would also do 50 ideas. But just completely different ways of thinking and different ways of being trained. I trained as a graphic designer and now doing more healthcare design consultancy, which we'll talk about, and also being an artist. And actually, interesting, you spoke about fashion and space, that kind of observing the world is very much what I do with my art. And we've spoken about this before, the idea that, should I introduce myself separately as a designer, something more corporate, I guess, and then as an artist. But actually being an artist is observing the world in quite a raw state, and actually being able to do that, even though it's maybe seen as a bit more, oh, you're an artist, that bringing that to the table, and lots of those ideas that then, lots of them not being good, can then be used. And I'm going off on a tangent. We did a project about longevity at uni, which I think was quite interesting, and this idea of wicked problem mapping, and that's what we've been doing within our practice since, and our work. Do you want to talk about kind of wicked problem mapping and that piece? Yeah,
and I think it leads on quite nicely from what you were saying before about how you describe yourself and that role as observing, because what we did in that project was take actually two ways of observing. So I would say, as a clinician, observation is my key skill too. Actually, I can remember coming to the end of medical school, and one of the key things I remember one of my tutors doing was taking me and a group of students, and we had to very quickly go around and go from bed to bed in A&E. And he wanted us to say whether we thought the patient was sick or not sick. We literally had to go sick, not sick, sick, not sick, lots of times, very quickly. And what he was teaching us to do was to take in a lot of information very, very fast. and come to and be synthesizing all of that evidence-based stuff that we've learned about, taking in how much urine output somebody's got and storing that, but not articulating it necessarily, but taking in that whole picture. And in that longevity piece of work, which was really grounded in things like complexity science and cybernetics, particularly cybernetics as applied to design, these different ways that you can take these vast volumes of information and synthesize them down in a way that you've got something tangible that you can tackle. And I can remember you and I having that discussion when we were doing that work of how we came up with our own way, didn't we, of actually kind of visualizing that and doing mapping. And we had quite a sort of clear aesthetic around river systems and water systems that allowed us to make some connections between all these data points that we've had and these information nodes that basically allowed us to identify places where actually that's an innovation opportunity, but really what we were doing is, it's what we both do in our original core jobs, that we are synthesizing a lot of information and then being able to do something with it, but bringing those two techniques together. And that for me has always been, that was a great foundation, because I think that's the way we've worked a lot in everything that we've done together.
Yeah, and everything, with me, whether it's my art and it's taking a landscape and using my memory to then visualize that and bring it together through brushstrokes, versus this podcast talking about ideas, turning them into action, like how do you synthesize all those ideas and bring it together. But then also within healthcare and our consulting, so with Root and Branch, which we'll go on to in a minute, how do you look at maybe a worldwide wicked problem, something huge, and that's very overwhelming, but how do you then take that overwhelmingness and visualize it and find and pinpoint those places of innovation? And I think that's the key, is that yes, you can map things out, yes, you can understand things, but unless you layer up with design thinking or just different methodologies, that communication, how do you actually then make improvement from there? And that's where I think we get on so well, work together so well, is how do you balance those two things, so then make action and make change, right? It's not just then that visualization, because I guess I was just gonna add, that's what I worry about, is that you say, oh, you're an artist, oh, you're a designer, how does that then make change? And that's my favorite bit, is how do you do that bit?
Is that bit about do you remember when we read The Craftsman, the Sennett book, and that idea that the thinking is in the doing, and for me that's quite Cartesian again, actually, or it tackles the Cartesian problem. It's not separated off. And I think there's that classic distinction, isn't there, between art and design, whereas actually there's a lot more flow between those two things, because the thinking, you're actually, in my world, we're doing that strategic thinking through the doing. And I think this is a in terms of thinking about how this relates to lots of different types of problem, I think things like artificial intelligence are really highlighting why that kind of ability is so important. Because one of the things that we've been talking about in some of my networks, and we wrote a piece quite recently around this, is that AI can almost, it can do some of the strategic intelligence, this classic kind of, hived off, not really to do with the doing intelligence. But artificial intelligence is not bad at doing certain types of that, not everything, but certain types of it. It can even mimic some of the sort of relational intelligence stuff, but it's only mimicking it. It's not really doing it in the way a human does it, where we talk about, in a therapeutic world, about attribution of meaning. And I think that's also really relevant in art. There is something about, what does this actually mean? What this thing that you've made, and that we have in our conversations therapeutically in psychiatry and psychology. What is the meaning here? And that's a very, very human thing. And I think what the conversations that we've been having recently around skill sets that are going to be important, for example, going forward, it's going to be that synthesis. So that's strategic intelligence, but knowing that AI can do some of that. But the relational intelligence absolutely being really very important. And then also this idea of how you embody those skills, so the thinking being in the doing. And I very much believe that people who are going to be able to do great things and bring their innovation to the fore, etc., are the people who can do all three of those and who can actually bring those three types of intelligence together.
Can you list the three again?
So it's the classic traditional type of intelligence is the strategic intelligence. So that's your academic performance, that kind of the classic way that's tested. Then there's this sort of thing, relational intelligence. This is this kind of, you might think about it as empathy, but it's a little bit more than that. It's about this whole pieces of behaviour. Some of it might be said, some of it might be unsaid. The stuff that comes between people and relationships, and especially around attribution of meaning. And then there is the kind of doing intelligence, the actual embodied intelligence. So those are the three.
Nice. Always likes threes. I was going to say, it's like, so we need to touch on root and branch and the connection, creation, care. There's another three. Do you want to introduce root and branch? We've mentioned it briefly, but what is it?
So it's really just a collective of people who are interested in these complex problems and are interested in looking at them in this way, with this transdisciplinary approach. So taking methods from scientific methodology and from the design world and thinking about these and bringing that together to solve real problems, and particularly in healthcare. I don't know, would you add anything to that?
Yeah, no, it's good. That's the pitch, isn't it? And that's what Leah and I work on together, looking at mainly healthcare, but different wicked problems, and going from that ideation and the kind of the mapping and the visualization through to actually having an action plan, and making useful innovation ideas and things like that. So from academic research, things like ethnographic research, through to UX, like user experience principles, through to more like design and I guess more art school principles as well, and how all of that comes under clinical advice and safety by design, all of the good stuff, but almost looping back to what we said at the beginning, the person being in the center, and how can you improve services and things like that from a person-centered way. Did I just complicate it?
No, I think that's right. I think that's absolutely right. It's also not being, thinking particularly about current work around neighbourhood, etc. It's not being constrained by current models. So it's being able to think more laterally about what's going to make the biggest difference to someone's health experience, but recognizing what you're doing is this model transition. In my view, you can get yourself into a bit of an echo chamber if you just keep doing the same thing over and over, and it takes quite a bit of that. I think it's that bit of holding of uncertainty that I think is really there in creative industries, but is not actually in scientific and engineering industries. And that's why that transdisciplinary approach is really important, because you need both. You need both that scientific rigour, and you need those methods that allow you to hold uncertainty and to iterate.
So thinking of ideas within healthcare and our work with Root and Branch, we've also got the Needy Network, which you have to explain why you called it that.
Yeah.
There's a healthcare design network that's got, I think, up to 100
it's
people
over 100
now.
I think now, yeah.
In our community.
Just a little WhatsApp group.
Yeah.
And started it because we were looking for where those clinical design conversations were really, and couldn't really find, they'd happen in little silos and little professional silos. And very much like how we met and saw the value in people from different disciplines having those conversations together. That's really what it was about. I mean, there's been a lovely conversation this morning actually that I was reading on the train. I don't know if you've had a chance to look at it around perceptions in for youth, mental health, and perceptions towards social media, stigma, and someone asked a question about engagement. And a number of different people have come with, I don't know what your view is on that. It was, sort of around, is it the same thing? Is adult engagement the same as youth engagement with various things? Do you look at it in the same way? I don't know. What do you think?
Oh God, I've got to read it later and get into it and put some research in. I think, well, from a social, think of AI, digital, growing up with all of that. It's tricky because I've literally just co-designed a paper, so that's a good example of taking a clinical paper and then actually designing it into a design output but from a co-design perspective with young people, and it was all about youth mental health and engagement with online mental health services. And I think that's interesting as a loop, that actually a lot of, and not to be too generalistic, but mental health being related to digital and social media, and then saying, well, you know, are you going to discuss with a bot your mental health? And I think, yeah, I don't know, it's a tricky one. It's that I'm getting stuck in the Instagram loop too much at the moment. And then I think, well, it's all just that, the whole algorithm just tricking and feeding dopamine. And, you know, and then even me as an adult thinking, oh, I should be better than this. Why am I lying in bed still scrolling? And then young people, how do they get stuck in the loop and follow the numbers and things like that? I don't know.
Yeah, I mean, from a neuroscience perspective, you know, you can really see dark pattern. You know, these are dark patterns, and they have a psychological basis, and we know that they're bad.
Yeah.
You know, and you can sometimes use them for good, but we know that, you know, they can sometimes really, really do harm. And I think it's going to take quite a lot of creative thinking. You don't want to lose the good things, right? Around those sorts of outlets. I mean, you're pretty active on social media. It's been really important for your work, hasn't it?
Yeah.
Like, what are the ways that it's? I think it's important to
the
remember
word
that's
of
good.
mouth is, so for me, building a design business, and then even like doing the masters, that was all through hearing about it through social media, meeting people. But not forgetting the importance in physical object and physical meeting of people.
Yeah.
You know, started doing a lot more healthcare design work when I published my book about cancer, 100 Stories of Cancer, and actually would show up to different NHS trusts and different meetings with clinicians and just hand them a book. And I think that difference, you know, almost got to come back to it, which is why I'm placing a lot of importance in physical art.
Yes.
You know, with my art now, I'm doing physical experiences, so actually going and painting live. And that's been very interesting, that people actually want to see the paint, smell it, hear from me, you know, how I'm perceiving a landscape, a house, whatever it might be, because they want that personal interaction. I feel like, yeah, back to your point with what was on the Needy Network this morning, maybe you need to map that out, and you'd have the layers of, from a design perspective, the good, the bad, the ugly, and all that. Yeah, it's all about data, isn't it?
Do you think that trend towards physical art is about, there's something about, it's, you know, with everything that's going on with AI and AI content, that people have that need to know who the human is, that it's at the core of something? You think there's...
Well, from a storytelling point of view, like, it's really important with social media now, what's getting the clicks is you explaining your background or showing your face, and that's that need for wanting to see the person. But then on the flip side, I might regret saying this, but I have once trained a bot, an AI model, to say it professionally, to paint like me.
Oh, really?
And you just fed this piece of tech with 50 paintings, and then you could prompt it, and the paintings would come out like my work. And so it made me think, what's on the internet that artists are showing that might not be their work? And so by showing you painting it, doing it in person, that's them removing that bias, right?
Yeah.
But how crazy is that?
But interesting. I would still say that's still different to you painting it, because we know that we know it's likely that your internal state is affecting in real time what the output is. It's that thinking and the doing bit, again, embodied skill stuff. I think there is a real, it's like when if I'm speaking, like I would say my medium is speech.
Nice.
If I pre-prepare something, I can sometimes make the mistake of over polishing it, and then my real emotion is a bit masked, actually. And the times where I think people have been most moved by what I'm saying is when I'm really, really conveying the truth of what I'm feeling. Even though they might not know what the truth of what I'm feeling, there's a difference. There's a qualitative difference, I think, in how I'm embodying what's going on internally for me.
It's definitely nuance. That's why my painting, I love going out and painting out in nature and standing by the sea, hearing the noise, seeing, you know, being hit by, I don't know if it's raining or whatever, or really cold, and how does that then affect the output? And I think, you know, even relating it back to our consulting with Root and Branch, we do a lot of workshopping and like live mapping out, and I think a lot of people within the healthcare design industry go like take lots of information, research, go away, present it, and then go away and put something together and then bring it back. Whereas we like to live on the edge.
Yeah.
And we do it live, that live mapping.
Absolutely. And there's something about in whatever space that you work in, there's something about you're often having to take people on a journey. Mm-hmm. So in a lot of the work that I've done in industry or, startup advisory, etc., there's a lot of that, because it's often people who are coming with something really quite new, the market's not really ready, and actually a big part of what you're trying to do is you're trying to educate the market. And if you've got your problem framing wrong, your product's going to fail pretty quickly. But if you've got your problem framing right and you've come with something really new, you then need to be able to take your market on that journey with you. And a lot, I think, sometimes that's what's happening when we do our workshopping, is that somebody's come with a new idea and we are helping orchestrate that journey of and actually allowing for that ideas machine iteration piece to happen, because it isn't a one and done. It's you're constantly iterating what that looks like and shaping it.
Yeah, and we've been asked a few times now to sit in with senior leadership teams, have discussion with them, from your clinical background, do almost lectures and talks on healthcare design and methodologies, to have that educational piece to then embed that thinking. Because I think that's the other thing with that kind of design methodology, is that you can do it once and then do a nice piece and visualize it and then say, oh, there's our area of innovation, let's go and do that now. Or you can really embed it into a team and continually use it. And that's almost where, with the podcast, this idea of the 3 areas to ideate, iterate and implement. Yes, okay, you do the ideation, you can visualize something. How do you then iterate and have feedback loops? Like, how do you synthesize and constantly improve?
Yeah.
Because it's not linear, it's constant improvement. And that's very heavy in the creative industry, but not necessarily in kind of clinical backgrounds, that you build a service, done.
And there's good and bad on both those sides, isn't
course.
there? Because I would say sometimes the criticism sometimes from around design-led techniques is that they're expensive, they've got endless cycles.
Let's just go again.
Yeah, go again. And I think there's something about, again, that transdisciplinary approach which allows you to not reinvent the wheel. It's like if you know let me think of a specific piece of work. So we did some work in my NHS England work around digital therapeutics in musculoskeletal conditions, and we took a transdisciplinary approach. So one of the first things we did was to look at the evidence base, which very clearly told us that in people who have back pain, the psychology of it tells us that they will tend not to complete their exercises if they have got if they're fearing the pain and they fear of making the injury worse. Mm-hmm. And in the way you tackle that service design means you don't need to reinvent that. You don't need to research that and find that out again. We know that, we've got enough in evidence base that says that. But you gear your discovery around how do you tackle that. So you can constrain things in a good way that leads to shorter cycles. It's cheaper, means you get to solutions quicker.
Yeah.
Can I just, before we end, can I ask you a question? You were talking about how, youth in terms of, all of these online social media
and I
platforms.
didn't really answer that.
No, have you heard about the case of that girl in America who sued TikTok for being predatory and malicious and keeping her on the app? And in a clinical space, I don't know if you work much with younger people or just all
not so much now, but I am actually doing some work around youth with that company.
In terms of what you've seen of this move towards AI and social media and everything is about engagement, right? How is that? And you also spoke about kids, the kids in Hungary, I think. Romania, who didn't receive certain things and that affected their psychology and some psychosis. We live in a world with AI psychosis and everything. What's your opinion on how we as a society, specifically young people growing up, all these things have shifted with malicious and the trappings of TikTok that are there to keep us on our phones?
So I think the really big concerns there's kind of 2 things I hear in my world. One is that it's a concern around what it's doing to our attention spans and how we engage with things, because these patterns are not new. That you know, the case with the girl suing TikTok, these patterns that are described in that case, they're not new. These are these dark patterns that we've talked about. So we know that, for example, in gambling, this is well before online gambling, these variable reinforcement schedules where you get like sometimes you win, sometimes you lose, and it's a you can't predict what that pattern is going to look like. They're the ones that are most addictive, those variable schedules. So we know quite a lot about the psychology of this and the psychology of addiction, and you can see these patterns playing out in how how engagement is driven with these things. And that's one of the things that actually in our work we're quite passionate about. So we talk particularly about inclusive by design, safety by design, and ethics by design. And the ethics by design here, I think, is really important, because you can do anything, right? So you have to be intentional. For me, you have to be intentional about what you do, because it really is a big problem. The other problem that I see, you asked the general question of what are people talking about as being the big problems, is this skill issue. So we know I'm doing some work around radiology algorithms at the moment, actually. And in that workforce group, one of the big concerns is, so we've got, these are great innovations, things like AI assisted diagnosis. We've got, it's improving productivity. We're getting more accurate diagnoses. But it also means that radiologists are de-skilling, because they're not doing that. Remember when I told you about that story about sick, not sick? They're not doing that in the same way. And that's a problem. That's going to means that particularly the edge cases, because AI makes things up, these things they're not reliable on their own. You need that at the moment. You need that human in the loop to be able to take account. It's actually about taking accountability for that diagnosis that's made. We know there's a problem, or potentially a problem, around losing these skill sets. And I would say the same is going to be true if we push really hard and we don't understand these problems that, like the girl who sued TikTok are highlighting. Really funnily, my kids, Tilly said to me the other day, my daughter said, "We're really glad, Mum, that you didn't put us on screens like all the time." I was thinking, I think I was quite permissive with screens, actually. But they were talking in relation to other people they know, particularly younger kids that they know. They're in their teens. And I was saying, why? She said, well, you can see, it's really obvious to them. They can see a difference in the way different kids engage. And I that was quite shocking to me, actually. I was like, because I've always worried about it. It's like we were quite early. We're sci-fi geeks, so we were always early adopters of technology and things like that. So I always worried about that. But I think there is this piece of, it's nearly always okay if you also have the physical in-person part, and you have that, you are still learning how to do that real communication. Exactly back to those children in the Romanian orphanages. That's what they missed. They did not have human connection. Yeah. So I think most of these things, they're fine as long as they are within the context of appropriate human connection and human interaction.
Do you think in the healthcare world, like you say that all of these new things coming in, they're using AI, are you seeing a problem of people or the whole system not using it well enough, or sort of letting AI lead where doctors should? Is that a problem?
So that example I was talking about, that's an example of AI leading. So we call that confirmation bias. So we're seeing that so that's a technical term, and it basically says, so what they will have to do is the way the kind of validation of the tool works is that you generally have to say accept or decline the diagnosis that the AI is given, and they're finding that people can't press accept or decline, and then they're asking them why, and they're like, well, I don't know, I haven't got enough information, or I'm not really sure, or actually there's a bit that they're not talking about, which is the fact that they're worried about their jobs. There's all these like complex factors informing these ambiguous decision making, and it's really oversimplifying this. We talked about complexity, how we both deal with complexity in all our different roles. I think that is a big thing. We don't really we take for granted what we do as humans in navigating a complex world. I think we really take that for granted.
Well, I'm going to say thank you very much. And also, where can people find you if they want to follow along? You're on LinkedIn. What's your name on LinkedIn?
My name on LinkedIn is Dr Lia Ali Ashlyn, but you'll find it if you put Lia Ali.
Very good. And thank you very much for being on the podcast. It was nice to talk about all our different hats and all our different work and crossover of work and work together.
Oh, we should have worn hats.
Yeah.
You should have worn your green hat.
I know. I should have done. I did my hair instead. And if you are watching, thank you for watching, because you could have watched this on YouTube and on Substack, and you can find us at theideasmachine.substack.com, and we're now on TikTok and Instagram at The Ideas Machine. So yeah, thank you for being here, thank you for listening, and goodbye.
Thank you.